Saver, you are about to take the module on tachycardia and its management, your fourth module for the Advanced Cardiac Life Support Training course of the Philippine Heart Association. At the end of this module, you should be able to recognize narrow and wide complex tachyarrhythmias, identify stable and unstable tachyarrhythmias, and know the appropriate management of different tachyarrhythmias. This will be the outline of this module. Before we begin, let me define tachycardia for you. Tachycardia is defined as a rhythm with a heart rate greater than 100 beats per minute. In general, we should think of possible clinical conditions and be able to check for the underlying causes. Clinically significant tachyarrhythmias are related to heart rate 150 beats per minute or higher. The likelihood of hemodynamic instability is higher with faster heart rates. In these cases, you must not only consider treating the underlying cause, but also consider immediate management. These are some of the common and clinically relevant tachyarrhythmias that you may see in clinical practice, and we will review each of them in the next slides. Tachyarrhythmias, as we see on ECG strips or cardiac monitors, seem to be challenging and intimidating. To make it easy, the first step that you must do is to look into the QRS complex and determine whether the arrhythmia is a narrow or a wide complex tachycardia. To determine whether the tachycardia is a narrow or wide complex, quickly measure the QRS duration. QRS duration is measured from the start of the Q wave to the end of the S wave. A narrow QRS tachycardia has a QRS duration of less than 0.12 seconds. This is an example of an ECG strip with a narrow QRS tachycardia. On the other hand, a wide QRS tachycardia has a QRS duration of more than 0.12 seconds, as shown here in this strip. What you see right now is a head-to-head comparison of a normal versus a wide QRS tachycardia. As I have previously hinted, tachycardia is categorized as a narrow and wide QRS tachycardia. Narrow QRS tachycardia is further categorized into a regular and irregular narrow QRS. The most common ones under regular narrow QRS tachycardia are sinus tachycardia, supraventricular tachycardia, and atrial flutter, which may be irregular in some cases. Under irregular narrow QRS tachycardia, we usually encounter multifocal atrial tachycardia and rapid atrial fibrillation. Wide QRS tachycardia is also further classified into regular and irregular wide QRS tachycardia. Under regular wide QRS tachycardia, ventricular tachycardia is the most common arrhythmia we encounter, and on rare occasions, we may encounter cases of supraventricular tachycardia with aberrancy or pre-excitation. Under irregular wide QRS tachycardia, we may see torsade de pointe, or less commonly, atrial fibrillation with aberrancy or pre-excitation. Dealing with wide QRS tachycardia is a bit more cumbersome because oftentimes these include arrhythmias that we likely haven't seen or have seen infrequently, such as these arrhythmias. So we will touch on this briefly. Let's just familiarize ourselves with these, but you are not necessarily expected to identify this during the megacode. In case these arrhythmias appear in your practice, better call or consult an expert to assist you in the management. Among all the different tachyarrhythmias, we will be focusing on these common ones, and I will walk you through each of these briefly. Sinus tachycardia is by far the most common tachycardia. ECG will show a rate of more than 100 beats per minute, with a narrow QRS complex, regular rhythm, and is a normal P wave followed by a normal QRS. Supraventricular tachycardia usually has a rate of 150 to 250 beats per minute, with sudden onset and termination. ECG will show a narrow QRS complex and a regular rhythm with no P waves. These P waves are not really absent, but they're actually buried in the QRS complex. Atrial fibrillation will show a narrow QRS complex, an irregularly irregular rhythm with no discernible P waves. Atrial flutter, on the other hand, usually has an atrial rate of 250 to 350 beats per minute. P waves are seen as flutter waves which look like a series of sawtooth on the monitor or ECG strip. Less commonly, we may encounter multifocal atrial tachycardia. Oftentimes confused with atrial fibrillation, MAT has narrow QRS complex, irregular rhythm, but P waves are still discernible. Diagnosis of MAT requires presence of 3 different P wave morphologies as seen on the monitor or ECG. Among the wide complex tachycardias, ventricular tachycardia is the most common. Because the impulse is ventricular in origin, P waves are absent. VTach with irregular rhythm is described as monomorphic VTach, and those that are irregular as described as polymorphic VTach. One example of a polymorphic VTach is torsade de pointe. The classic defining characteristic of torsade is the twisting of points along the isoelectric line as seen here. Let us now discuss stable and unstable tachycardia. One of the important steps in managing a patient with any tachycardia is to decide whether the patient is stable or unstable. This is because the treatment approach to each patient with tachyarrhythmias is not just based on the patient's rhythm, but on the patient's hemodynamic status as well. An unstable tachycardia exists when cardiac output is reduced to the point of causing serious signs and symptoms, which may present as hypotension, altered tensorium, signs of shock, chest pain, and heart failure. Absence of these signs and symptoms of hemodynamic instability defines the patient as stable. Now let's proceed to the tachycardia algorithm. The first step in the general ACLS algorithm is to identify the rhythm correctly. Once you have identified the rhythm, you should check for the presence of pulse within 10 seconds. If pulse is appreciated, assess the patient's clinical condition, and typically, the heart rate is more than 150 beats per minute. Once assessment is done, identification of causative factors is equally important before initiating invasive interventions, as most of this can be reversible. It is important to assess breathing as necessary, and for cases of hypoxemia, you should maintain patent airway and administer oxygen supplementation as needed. Cardiac monitoring is also a must, as well as establishing IV access, and if feasible, do a 12-lead ECG. For tachycardic patients with a pulse, the next question that you should ask is whether the patient is unstable or unstable. If the patient does not have hypotension, altered tensorium, signs of shock, chest pain, or heart failure, then the patient is considered stable. For stable narrow regular tachyarrhythmias, particularly SVTs, you can perform vagal maneuvers first before trying any drug. But make sure that this maneuver is safe for the patient by auscultating the carotid arteries and making sure you do not hear any bruit that may indicate presence of plaques. Massaging the carotids may disrupt the plaque and may result in embolic stroke. Other stable tachyarrhythmias may respond to drug therapy. After administering any form of intervention, you have to check the rhythm again to see whether the arrhythmia was successfully converted or not. The next few slides will show the common drugs that we use for narrow QRS tachycardia. The first drug that we will discuss is adenosine. Adenosine works as an AV nodal blocking agent and is the drug of choice for SVT. Adenosine has a short half-life of less than 5 seconds. Thus, it is important to place an IV access in the antecubital area for ease of administration, followed by a 20 ml saline push. Do not forget to raise the patient's arm to hasten the delivery of the drug. Initial dose is 6 mg via rapid IV bolus. If the rhythm is not converted, you can give a second dose of 12 mg of rapid IV bolus, and a third dose and last dose of 12 mg IV bolus. Another drug for tachycardia is verapamil. It is a non-dihydropyridine calcium channel blocker that is used as an alternative to adenosine in stable SVT. It can also be used as a rate controller for stable atrial fibrillation or flutter. It is contraindicated in patients who are known to have heart failure and low blood pressure. Initial dose is given at 2.5 to 5 mg low IV push for 2 minutes and can be given every 15 to 30 minutes until a maximum dose of 20 mg is reached. Beta blockers belong to another class of medications that act as competitive inhibitors of beta adrenergic receptors. They are widely used for supraventricular and ventricular arrhythmias. However, they are contraindicated in patients who have low blood pressure, history of active bronchospasm like asthma and COPD, and heart blocks. One example of a beta blocker is esmolol, which you give at a loading dose of 0.5 mg per kilogram IV over 1 minute, and then followed by 0.05 to 0.2 mg per kilogram per minute as maintenance infusion. Another example is labetalol, which you can give at an initial dose of 10 mg low IV push over 2 minutes, and may be repeated every 10 minutes until you reach a total maximum dose of 150 mg. For wide QRS tachycardia, the most common drug that we use is amiodarone, that acts by prolonging the action potential duration and decreases AV node conduction. It is also widely used for supraventricular and ventricular tachyarrhythmias. You should give this drug with caution, especially to patients with low blood pressure. Initial dose is 150 mg low IV push for 10 minutes, followed by a 1 mg per minute infusion for 6 hours, then 0.5 mg per minute infusion for the next 18 hours. You can also use lidocaine, that is a sodium channel blocker. It can be used as an alternative to amiodarone if the latter is not available. You give this drug at 1 to 1.5 mg per kilogram IV bolus. A second dose can also be given at 0.5 to 0.75 mg per kilogram IV bolus. Magnesium is also an important drug in tachycardia and is used for termination of Torsades de Pointes. Magnesium is prepared by diluting 1 to 2 grams of magnesium in 100 ml of D5 water to be given as an infusion over 1 to 2 minutes. If the patient shows signs of hemodynamic instability and is deemed unstable, then your best approach is electrical therapy with synchronized cardioversion. Again, after an intervention is given, reassess the rhythm, whether the arrhythmia was successfully converted or not. So how do you perform synchronized cardioversion? Synchronized cardioversion involves the delivery of a low-energy shock that is timed or synchronized to be delivered at a specific point in the QRS complex. By timing the shock, electrical stimulation is avoided during the vulnerable period, which reduces the risk of inducing ventricular fibrillation. The energy level used is lower than the fibrillation. The fibrillation, on the other hand, uses high energy, which temporarily stunts the irregularly beating heart to allow return of spontaneous circulation. Cardioversion is indicated in unstable and refractory tachyarrhythmias. Synchronized cardioversion is administered to unstable and refractory tachyarrhythmias, such as unstable supraventricular tachycardia, atrial fibrillation, atrial flutter, and monomorphic ventricular tachycardia. The following are the corresponding initial doses for each rhythm morphology. For narrow regular rhythm, give 50 to 100 joules. For narrow irregular rhythm, give 120 to 200 joules when using biphasic machines, and 200 joules for monophasic machines. For wide regular rhythms, give 100 joules. For wide irregular rhythms, defibrillation is done instead of synchronized cardioversion. I will now guide you through on operating a defibrillator in delivering a synchronized cardioversion. Step 1. Sedate the patient. Step 2. Remove any transdermal medications on the chest. Shave the chest if possible to ensure adequate skin contact with paddles. Chest hair can increase transthoracic impedance, which affect success of cardioversion. This could be reduced up to 35% by shaving. It is recommended to shave prior to shock. Step 3. Apply gel on paddles. Release the paddles from the machine by pressing on the buttons encircled in yellow. Then squeeze enough amount of gel into the paddles. Step 4. Turn on the machine. This picture is an old monophasic machine which is still being used in some hospitals in the country. On the right is a newer model. The red arrows both point to the on button. Step 5. Press the sync button. In old models, you can see a separate sync button. For newer models, you will see a sync button on the lower right corner of the monitor. For both machines, you will be seeing dots or arrows pointing to the QRS complexes on the monitor. Select the energy level required by turning the dial in the old model or pressing the Energy Select button in newer models. Step 7. Press the Charge button. You can also press the yellow button on the paddles to charge. Once charged, the word Ready will be displayed on the screen. Ensure proper placement of the paddles and electrodes, following these anterior lateral positions. Step 9. Check the surroundings. Make sure everybody in the team is clear. Step 10. Press the discharge or shock button on the paddles or on the machine. Do not remove the paddles until shock is fully delivered, as displayed on the screen. Moving on, what are the do's and don'ts in tachycardia? It is important to always assess the hemodynamic status of the patient, QRS duration, and regularity of the rhythm when evaluating a patient. Efforts should be made to determine the primary cause of the presenting symptoms, and looking for underlying conditions is imperative. These are the 5 H's and 5 T's, a mnemonic that you can use when looking for common causes of arrhythmias. For unstable tachycardia, defibrillation is not an option. You do not defibrillate unstable tachycardia. Instead, you do synchronized cardioversion. For unstable fast atrial fibrillation, you do not cardiovert haphazardly. You check first on the duration of AF before deciding whether or not to go for cardioversion. That is to prevent an embolic event in cases of chronic atrial fibrillation. For wide complex tachycardia, do not take too much time studying the ECG. You may want to treat wide complex tachycardia's VTAC when in doubt. As an ACLS provider, you should not panic. Interventions should not be delayed, especially if the patient is unstable. Remember, do not treat the monitor, treat the patient. I will now give you 2 sample cases as a form of exercise. Let us see what you have learned and can remember about managing tachycardia so far. Case 1. You received a 37-year-old female at the ER. She is complaining of palpitations. You hooked the patient to a cardiac monitor that shows this rhythm. What is your diagnosis? Yes, you're right. It's supraventricular tachycardia. Good job. You went to check her vital signs. Her blood pressure is 80/50 millimeters mercury. What should you do next? A. Defibrillate at 360 joules. B. Give IV epinephrine. C. Give IV adenosine. Or D. Do synchronized cardioversion at 50 joules after sedation. The answer is D. Do synchronized cardioversion at 50 joules after sedation. You got it right. Good job. For cases of unstable tachycardia, the appropriate management is cardioversion. Upon reassessment, her blood pressure went up to 110/80 millimeters mercury. What should you do next? A. Do synchronized cardioversion. B. Give IV adenosine. C. Give IV atropine. Or D. Give lidocaine IV bolus. The answer is B. Give IV adenosine. You got it right. Good job. For cases of stable SVT, the first drug of choice is IV adenosine. Despite maximum doses of adenosine, verapamil and esmolol, the rhythm remains the same and BP is stable at 110/80 mm mercury. What is the next appropriate management? A. Attempt cardioversion. B. Attempt vagal maneuver. C. Give IV atropine. Or D. Lidocaine IV bolus. The answer is A. Attempt cardioversion. You are correct. Good job. For stable tachyarrhythmias that are refractory to medications, you can attempt to do cardioversion. I give you case number 2. It's a case of a 70-year-old female who is admitted to the ICU. She is being referred to you because of this rhythm. What is your diagnosis? The answer is ventricular tachycardia. You are correct. Good job. Upon checking her vital signs, she has no BP, thus pulseless. What should you do next? A. Do synchronized cardioversion at 200 joules. B. Defibrillate at 360 joules. C. Give IV epinephrine. Or D. Give IV lidocaine. If you answered B, defibrillate at 360 joules, then you are right. Good job. The patient has pulses V-tach, hence you should proceed with defibrillation as what you have learned previously in the arrest algorithm. On reassessment, the patient develops a pulse and with a blood pressure of 50 palpatory. What is your next step? A. Synchronize cardioversion at 100 joules. B. Give IV verapamil. C. Give IV adenosine. Or D. Defibrillate at 360 joules. The answer is A. Synchronized cardioversion at 100 joules. You are correct. Good job. Again, for unstable tachycardia, you opt for synchronized cardioversion. On reassessment, the patient's blood pressure goes up to 110/70 mm mercury. What is your next appropriate step? A. Synchronize cardioversion at 100 joules. B. Give IV amiodarone 150 mg slow IV push. C. Give IV epinephrine. Or D. Defibrillate at 360 joules. If you answered B, IV amiodarone 150 mg slow IV push, you are correct. Good job. Since the patient has become stable, then you can opt for drug therapy. Finally, do not forget these key points for managing tachycardia. First, always check for pulse and blood pressure. For stable tachycardia, you generally give drug therapy. For stable narrow QRS tachycardia, you can attempt vagal maneuvers in addition to giving medications. For stable wide QRS tachycardia, go for medications too. If the tachycardia is refractory to medications, then you can use electrical therapy or cardioversion. When dealing with unstable tachycardia, you opt for synchronized cardioversion. It is important to remember the energy levels for cardioversion because these are certified must-knows as an ACLS provider. Thank you for listening. You are now ready to take up the module on airway management and ventilation.